Yeah. Before the next lecture from Sir is starting, I want to ask Sir: is in this guidelines, do we have any timing like all the antihypertensive medication should be taken? Because there was one paper in Cardiology Journal regarding taking the antihypertensives during the bedtime usually decreases cardiovascular mortality. So, is there any guideline on like when to take these medications as such in 2022?
Sundar, let me just say that the ADA clinical practice guidelines have been put to bed for 2022. There is nothing about this. And by the way, do not delude yourself. There is zero data supporting nighttime dosing. That one paper that you talked about has been retracted from the New England Journal. There have been 3 other well-done studies randomizing dosing nighttime versus daytime. We did one of those studies a few years ago. There is zero data supporting nighttime dosing for better blood pressure control, period. Interestingly, and this remains to be seen, there is a paper coming out from a study that we did, an ABPM study with finerenone. And finerenone seems to improve, and this is not nighttime dosing, this is morning dosing, seems to improve nighttime blood pressure. And this needs to be further studied, but it's quite interesting. Daytime blood pressure doesn't do anything. Nighttime blood pressure seems to reduce it. So we don't know why. It's an observation. We'll see, but nothing for glucose. Forget it.
Dr. Bakris, can we change non-dippers to dippers by any way? I mean, patients who have non-dippers, and we know that they have a higher mortality.
Oh yeah. The short answer is to a certain extent. If they have sleep apnea and you improve sleep apnea, yes, that seems to help a little bit. Possibly finerenone, we don't know. Nothing else seems to really help. Weight loss, dramatic weight loss. I'm talking about people that have had surgery, 70 pounds, 90 pounds. There's some small studies, very small, that suggest maybe improvement there. But the true mechanism for why this is happening in the first place is unclear. People were postulating hypoxia. Probably not. Is it inflammation? Maybe, but inflammation you can blame for everything. So we don't understand it. We don't know. Just like I can give you 15 mechanisms by how SGLT2s work, and they're not all in the kidney. So we don't know.
In the 2022 guideline, is there any change in the targets of blood pressure in diabetics?
No, still less than 130 over 80.
130
still
over 80.
less than 130 over 80.
Good. And yes,
sorry, please go ahead, sir.
Yeah, I was just asking, what are the other changes specific to diabetes with hypertension?
Well, Sundar actually touched on it. If you're seeing somebody with diabetes and they have either kidney disease, GFR less than 60, and or heart failure, regardless, HFrEF, HFpEF, they need to be on an SGLT2, period. Now, if you want to use it to control glucose, that's fine, but they need to be on an SGLT2. Now, you want to use metformin, please. Nobody's stopping you. Be my guest. Metformin is still there, but it needs to be married to an SGLT2. And Sundar made a good point. Let's say you don't have kidney disease. Let's say you don't have heart failure, but you've had an MI. Guess what? You need to be married to a GLP-1RA with the metformin.
Any changes in the other drugs like the ARBs being the other drugs which are specifically indicated in diabetes with hypertension?
No, come on. That's mom and apple pie. The ARBs, it's a given that you're going to be on an ARB or an ACE inhibitor. Right? That's if we're having a discussion about that, we have big problems. Okay. That you have to be on for sure for blood pressure, period. Now, for additional blood pressure medicines, the first question, very important question, did you measure the urine for albumin? If you didn't, I'll see you in court for malpractice. It's very, very important that you measure albumin. Otherwise, you really don't know what the level of kidney function is. If you have large amounts of albuminuria, then ARB has to be on board, SGLT2 has to be on board, non-dihydropyridine diltiazem can be on board as an additive benefit. All of those things help in slowing kidney disease progression in the diabetic.
I think Sundar, you also said this point about albuminuria being one of the very important factors. Sundar, you also highlighted this, Sundar.
Yes,
You
and
also
I've
about
but albuminuria, I know I have
you highlighted,
clarified this with Dr. Bakris, is a better predictor of cardiovascular disease than it is. But the biggest hooker there are people with normoalbuminuric kidney failure. They go down to zero, no protein in the urine. So that
that's a great entity. Bakrish, would like to say something about that non-albuminic.
Sundar is absolutely right. And it's estimated it accounts for about 10% of all people with diabetes having so-called non-albuminuric kidney failure. Nobody has a clue. That's the number one question Vivian Fonseca asks me. What's the mechanism? Well, if I knew that, I'd be in science. I don't think anybody knows why. It's postulated that it's interstitial disease, and somehow the glomerulus gets away with it. That makes zero sense. So I don't understand. Sundar maybe has a hypothesis for this. I really don't know, and to my knowledge, I've asked. Nobody else seems to know.
Yeah. My hypothesis is, and just for the record, I had the privilege of debating Dr. Bakris at American Heart, if you remember, in 2019. He said SGLT2 inhibitors are hemodynamic, and I said it is the fuel hypothesis. And I was really nervous.
We all learn. I do remember. We all learn.
We learn, we live, and we keep learning over there. But to me, so I always tell people, and this goes back to the person who taught me nephrology in Madras. I'm blanking on his name. I can't believe. He's in Apollo. He was a nephrologist. Doctor?
30 seconds.
Money, Dr. Money.
MK Money.
MK Money. Thank you. Thank you for that. He stimulated this interest in me in the 1980s over there. Everybody says the kidney is a filter. I said there are two organs in one. There is the filter and there is the pump. And I tell people, the filter, the glomerulus, it does not have much of an energy consumption because the energy for it is the heart, which has pumped the blood and it just goes through. The tubule has to do all the thing. 80%, and Dr. Bakris can cut this thing, of the energy consumed is that K-ATPase pump, which it is using. Now, whether it takes it back in the PCT, the loop of Henle, wherever it is, it has to do it. And the other point, so my point is, the glomerulus is okay. I mean, hyperglycemia can damage it, and then the protein leaks through. Protein is toxic to the interstitium and all that. You get the fibrosis, you get a lot of things. And in hypertension also, there's is it increase intraglomerular pressure, which is forcing its way through. But I believe, these people who are, now it is my speculation, there is tubular hypoxia taking place, because diabetes to me is also tissue hypoxia at the level. And in the inner medulla of the kidney, and Dr. Bakris, correct me if I'm wrong, the PO2, the partial pressure of oxygen is about 10, 15, 20. It cannot support oxidative phosphorylation. So the fuel there has to be purely glucose in the glycolytic thing. You cannot use anything else. And the beauty also is the guy who's doing most of the work, the PCT, the proximal convoluted tubule, glucose is not a preferred fuel there. Ketone is also not a preferred fuel over there. They use fatty acid because it's a big thing over there. And the reason we don't know yet why glucose is not preferred is those cells are the ones which do your gluconeogenesis. They're the ones sitting over there. So nature doesn't want a futile cycle. You make it and you use it. That kind of doesn't make sense. So the fuel thing is different all through it. And my thing is that with SGLT2 inhibitors, ketones become a fuel. I don't know if it is right or wrong.
So wait, so Sundar, I agree with everything you said, and I want to add one thing to you. The kidney is not two things. The kidney is three things. It is also an endocrine organ, because let's not forget about renin. let's not forget. I mean, let's just,
Erythropoietin.
Erythropoietin.
Erythropoietin. And the
okay.
fascinating
I
thing
mean,
is,
that's
in
fine.
fetal life, sorry,
Yeah.
in fetal life, the liver makes erythropoietin. The moment you're born, within a week or two, the kidney. And this fascinated me. I've gone back and looked at all the original literature about why is the kidney sensing hypoxia. We have all the carotid body, this and that. They're not sensing hypoxia. The
See,
paracortical cells. And I'd be interested in your thoughts. I have my own thoughts.
no. I agree 100%. And you brought up something that unfortunately can only be looked at a basic science level. And that's why clinically, one could argue that SGLT2s are protecting the kidney in a mechanism that is not too different than is protecting the heart in terms of metabolic pathways in the hypoxic state. Has not been examined. So
yeah, it's not been examined. Absolutely.
Yeah.
So what happens, this is my thing. So, we all check, the finger ox, it's 98, 96, 92, we're okay. But from 90 to 98 is a 8% drop. That's, you might say, hey, it's nothing. But in the kidney, if it drops from, in the medulla, if it is dropping from, say, 20 to 12, that is a huge, that's a 50, almost 50% drop. So it is uniquely poised to pick up small, clinically relevant things. And those, it is at the paracortical junction of those, they are actually neuroendocrine cells which are there, which make the erythropoietin. When they are hypoxic and they don't, they become fibroblasts. They de-differentiate, as it were. And all the SGLT2 studies that's been shown, erythropoietin goes up, hematocrit goes up, they rejuvenate them. The Japanese have done a lot of work on that, looking at the re-differentiation of those cells.
Dr. Bakris,
Just my thoughts.
Regarding, is there any other tubular dysfunction beyond what Sundar described in diabetics? Tubular dysfunction.
well, yeah, you can develop renal tubular acidosis, which is common. Usually it's longer term. And again, I think Sundar said something, and I'm going to come back to it. The workhorse of the kidney, everybody thinks the workhorse is the glomerulus. The workhorse of the kidney is the proximal tubule. And the amount of energy that is needed, the reabsorption that is occurring, the homeostasis that's responsible for is just out of control. Now, yes, long-term, the distal tubule, you can develop renal tubular acidosis there because so basically hydrogen and potassium are not going to be in sync. But guess what? That can happen at the proximal tubule as well. So there are a number of things that can, it's amazing to me that the focus is on glomerular diseases when in fact the tubule can have all kinds of things go wrong with it. And most of the time it doesn't. So it's kind of a big deal.
Yeah. The second question is what Sanjay had asked you. Isha, just 1 minute, Anjali. The second question to ask you is that Sanjay asked you about the dippers and non-dippers. And we know the non-dippers in diabetic have some sort of a subclinical hypertension, whatever you call it. And they're also prone to kidney damage because of diabetes, almost equal to people who are hypertension. And of course, you have given is there any specific mention about managing them in the new guideline?
There is nothing in the new guidelines about that because that is not well understood. I can tell you, I just finished writing an editorial. It's not published yet. It's going to be published next month in Hypertension on the longitudinal trajectory of blood pressure. And so if we look at this mathematically, and we look at the total area under the curve of blood pressure, not what is it in the office, what is it at home, the total area under the curve. The kidney not only modulates blood pressure, but it's a good buffer of blood pressure to protect itself within a certain range. But if you reset everything at a higher level, that protection erodes with time. So if you have diabetes, and now on top of that, you got a blood pressure, not real high, but let's say 150, all right? The kidney will protect itself to a certain extent, but if you start getting spikes through the day, and they become more frequent and the pressure is up at night, the kidney loses this ability to protect itself and you will get faster declines in kidney function. And one of the things that predicts this, believe it or not, is quality of sleep.
Absolutely.
Quality of sleep. I'm not talking about sleep apnea. That's a given. But I'm talking about people that have anxiety. They can't get to sleep, or they get to sleep, but they stay asleep for 2 hours. Then they're up. Then they can't get back to sleep. Those people are disasters in terms of blood pressure, in terms of speed of kidney function decline, in terms of glucose control across the board. And until you fix that, and you can't fix it with just giving blood pressure medicine or glucose, you got to fix the sleep, then you're okay.
Fantastic answer. Anjali, you had some question?
Yes, sir. So this is related to Dr. Murlia sir's talk on ancient to current management of diabetes. And I really, it was passionate, spontaneous. I don't have words. But I want you to help me to know whether I have understood correctly, sir. From ancient times to now, what I think, especially when you mentioned that the SGLT2 inhibitors have taught us diabetes like nothing else has taught us. And I think these two separate, because the treatments that were done, especially of the ketogenic treatments that were done with the nutritional and the metabolic parameters, changing herbs and all that. So here aren't there two distinct differences? One where people are born with a carbohydrate metabolism problem, like type 1s, and people with autoimmune disorders, autoimmune defects in the carbohydrate metabolism pathway, insulin, glucagon, and all that. And then we have certain who are born with a tendency but are dealing with a fuel and a fluid overload, isn't it? I mean, that we are only talking about fuel calories, I understand, but I think haven't SGLT taught us that, SGLT2 inhibitors taught us that there is also an overload of fluid that we have to deal with? And because we are removing the fluid and it's giving such an important results in improvement of kidney function, heart function, apart from hyperglycemia management.
I mean, it's a very complex question. Let me do it. But if I may make a point to the renal tubular acidosis, there are very few patients. I've had some patients for a long time. It's type 4 RTA, and these are the patients. People will say they're on Lasix or something, and they're on fludrocortisone for the the hyperkalemia and all that. So I've had people will say, what are you doing? You're using fludrocortisone, you're retaining sodium, and then you're giving Lasix. But that's the only thing that kept them going. So, and it is the hyporenin hypoaldo. And for the fellows in endocrinology, I always say, what is the hyperrenin hyperaldo? Barter's syndrome and Dr. this thing. So there are two separate things over there. But coming back to your question, see, this has fascinated me as well. And if you've listened to Dr. DeFronzo, he's a nephrologist and an endocrinologist, and he said, this is what he said in one talk. When the big guy in the sky put the kidney in, he told, you have two jobs, right? You need to keep the salt in, because if you don't keep the salt in, you don't have blood flow, you can't live, you don't have a vascular compartment. But then when you have the flow, you need nutrition. So he said sugar, and the transporter in the gut and in the kidney is the sodium glucose. But the body prefers sodium. That is the active transport. Glucose just sits on its back and gets in over there, because you can use fat for energy, you can use, and then there's a very complex procedure to convert protein into carbohydrate. You cannot convert, in humans, you cannot convert fat back to glucose. Glucose can become fat, but we don't have the machinery to put it in there. So the nature, and actually this goes back to Dr. Bakris says, when we came out of the ocean, we were living in a water environment. That is why it doesn't make sense that we are, trying to salt when we lived in that environment. And now we have to protect to keep. So sodium, glucose are both there. They are both running together. So I take your point that, it is salt. But I do not believe, type 1 is a different disease that is purely over there. But in type 2s, now you could have the metabolic syndrome, but the genetic component is very small. It is the environmental thing which we do to ourselves. And the body has got, Dr. Bakris can bear your tremendous reserves to adjust. You can eat 10 packets of chips a day. If your kidneys are good, it'll get out. You can drink 20 cups of water a day. All you're going to do is pee. The body knows how to. That's the beauty of the inner medulla, that's why the oxygen is low, because there is no blood flow there. Otherwise, you wash out that gradient to take back all the sodium. So I don't know that I've answered your question, but salt and sugar go together. Salt is more important than the sugar to the body. I don't know. Dr. Bacchus can add his thoughts.
No, I was listening and I'm just thinking that one of the things I tell the patients is the kidney, God knew that we were going to be stupid and we would abuse ourselves. And so think of the kidney as workers on an assembly line. And so the work comes, all the nutrition, the salt, the glucose, it all comes and they're handling it and all it's fine. Okay. But now you've increased the assembly line, the same number of workers, but now you've got 5 times the work. Most of the time in the factory, those people would quit. Here, the kidney does it. And ultimately, some people are going to die off because they can't take it. But there's endurance built in to our bodies, and that's why we're doing so well. But the one other thing that Sundar knows, didn't say this because he was focused on the kidney. One of the things I also tell the house staff is that the heart and the kidney are a married couple, and they actually talk to each other. They've got hormones, they've got nerves. There's all ways to talk to each other. If one isn't doing well, the other one is going to try to help, but it's not going to do well either. And it's going to try. And ultimately, if one starts failing, the other one's going to fail. And you can do this, what you can to support it, and it will support it. But the thing that people don't appreciate is beyond that. I will tell you, I was at a meeting. This was a large clinical trial meeting. 700 people are from all over the world. And I got up and I said this. I was followed by a cardiologist who echoed it. And then Peter Rossing got up. Now, Peter Rossing's an endocrinologist from the Steno in Denmark. And Peter and I are good friends. We were all good friends. And Peter goes, well, George, if that married couple is there, they're living in my house, the endocrine environment. And it's actually very nicely put, because guess what? The gut in kidney failure, and not dialysis, but reduced kidney function, the gut reduces the amount of branched chain amino acids it puts out, the bacteria. Guess what? The heart needs those branched chain amino acids for energy. So all of a sudden, you've got an energy deficit. So this is integrated physiology at its best, and it's really complex. And I just wanted to put that out there to say that, yeah, we can talk about the tubule, we can talk about the macula densa, but by the way, there's a whole environment. You're talking about a part of one room in your house, but the rest of the house is there. So.
Good.
So Sundar, I have a question for you.
Sanjay,
You've now seen the benefits from DAPA-CKD and credence and all this, where you've seen they've included patients all the way up to GFR of 25, and there are reports about using metformin even in low GFR patients, and it really doesn't cause too much of problems, and anecdotal lactic acidosis. Do you think, I mean, that's a gray area that I'm treading into, and I don't know what your thoughts would be, but
let me tell you.
Yeah.
Now, wait a minute. All right, ask your question. I'm sorry. Ask your question.
So do you think we need to revise the guidelines to see that we should stop saying that, we should stop using SGLT2 below 45, and we should stop using metformin again below 45 again? Yeah. So what are your thoughts about this? Should our guidelines be revised?
So SGLT2s, so the 2022 guidelines, SGLT2s can be used down to 25. Okay. Now, you may not know this, because I'm not sure it's actually online yet, but it will be eminently. There is a paper out of Canada. It's a small study, 250 patients, something like that, looking at sotagliflozin in stage 4 CKD, stage 4. And what they found was it was perfectly safe to be used down to a GFR of 15. And there is a study going on right now in England in dialysis patients with SGLT2s, specifically looking at the heart, obviously. But the 2022 guidelines will say SGLT2s down to 25. Now, metformin, with all due respect, is freaking poison if you're using it to GFRs down below 30. No way. And it's unappreciated the amount of lactic acidosis that occurs in patients that are not that compliant when you're between GFRs of 30 and 45. It's not that bad, but it's there. So for me, I automatically cut the dose, and this is the recommendation. When you get to 45, you automatically cut the dose to 500 BID. And I got to tell you, for me, when you get to 30, 35, I stop it and I move to other things. And I'm a big fan, since Sundar mentioned Ralph, I'm a big fan of pioglitazone. And I use it at 7.5 milligrams. I may go to 15. I don't go any higher, but I've had amazing results with that. So, and there's a stroke benefit, as you know, from the data. So, that's my 2 cents as a nephrologist.
Thank you. I think, Sanjay, it is time. And it's my Sanjay. We
Can I make one point? Sorry.
Yeah. Yes. So,
Yes,
No. I agree exactly. 45, 30 to 45, and below 30 in the US, of course, like he said, I'll see you in court. So you're running on things. But we didn't touch on one aspect of the kidney. Now, lactate is not the problem, but it is secreted as lactic acid, the H ion, and the kidney does your acid base. You can do a little bit with the respiration, but the kidney has to do the metabolic part of that. You can't deal with that acid load if you have a bad kidney. Lactate is a good fuel. You can do lactic dehydrogenase and take it back to pyruvate and do it. But the H ion is the problem over there.
Dr. Isha, you want to ask something before we close up?
Isha?
Please.
Yeah, that's it. So I don't know what else to say. Yeah.
Thank you very much, George. Thank you very much, Sundar. And thank you, Sundar, for stepping in for George
Yes,
at the last
thank
minute.
you. Thank you.
But
The last time I stepped in for Dr. DeFranco, if you remember, in Pune.
That's true. That's true.
That's becoming a habit with you.
But good, Dr. Bakris came back, Sanjay. And
yes, thank you so much, George.
Thank you. Thank you. I'm sorry.
We did discuss the diabetes guideline 2022. I mean, that was your subject for the second talk. Thank you, Bakris. And
thank you.
Thank you very much. It was an excellent session. And I would like to close the session and thank Dr. Das, Dr. Isha, of course, Dr. Sundar and Dr. Bakris need not be thanked. I mean, we should thank more than anything else, because they spare time and come and grace this platform to give such excellent lectures. So thank you, both of you. And we look forward to have you physically next year in Pune.
Okay.
Face to face.
Thank you.
Thank you, everyone. From the
thank you.
scientific committee, we close the session today. You want to say something?
And we would like to remind everybody we will start at 10 o'clock in the morning tomorrow.
No, 8:40 in the morning.
Sorry,
tomorrow.
8:40. Thank you so much.
Thank you. Thank you.
Bye-bye, everyone. Join in tomorrow by 8:40.
Thank you very much for giving the opportunity, Sanjay. Thank you very much. Me and Isha, thank you profusely.
Thank you, sir.
Thank you, Anjali. Thank you, Sanjay. Thank you. Bye-bye. Bye-bye. So I'm leaving the meeting. Bye. Isha, bye. Good to meet you.